Welcome, everyone, to today's webinar. This is Caroline Latour with the American Hospital Association, and I'm pleased to introduce today's webinar, the American Hospital Association's annual survey update. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing your question into the Q&A box. We'd like this session to be interactive, so we look forward to seeing your questions. If you have trouble with your audio, please try refreshing your browser. You may also submit any technical questions into the Q&A box. At this time, I'd like to turn the presentation over to our speaker, Andy Chow, Senior Director of Data Products at the American Hospital Association.
Thanks, Caroline. Hi, everyone. As Caroline just said, I'm Andy Chow. I'm Director of Data Products at AHA. My job entails taking some of the data assets that AHA creates and turning them into commercial products that our customers use to support research and inform decisions. Today, we're going to talk about AHA's annual survey and specifically about the new data set, which we're getting ready to release at the beginning of December. So our agenda, I'll start with an overview of what the annual survey is and the steps we take to ensure its quality and completeness. I'll spend a little time talking about what's in the upcoming release, including a sneak peek at some of the new items related to AI, telehealth, and workforce strategy. And then I'm going to do a short demonstration of Data Query AI, which is a new chat-based product that we've launched this year that lets you run simple searches and complex analysis through a chat-based interface that actually sits on top of the annual survey. We're excited to show you the new capabilities. And also, I find that it's a good way to illustrate how the annual survey data can be used. If all goes well, we should have about 10 minutes at the end for Q&A. As Caroline already mentioned, please feel free to submit questions along the way. So every year since 1946, AHA has administered a comprehensive survey to every hospital in the United States and U.S. territories. The data from that survey serves as a census snapshot of the field that we use in our own advocacy and that we license to other organizations to support their research and planning. The survey contains about 1,300 individual data fields. That varies from year to year. And it is set up to support cross-tabbing, longitudinal research, and joining with other data sets. Designing, fielding, processing, and publishing the survey is a full year effort by a big team of people. The survey instrument itself is finalized and distributed to hospitals in the first quarter. During the spring and summer, we collect data and process results as they come in. And then in the fall, we're into final data cleaning, our estimation process, and file production. The new data set is released to customers during the first week of December. So as I've already said, that means we have brand new data coming in the next couple of weeks. I wanted to take a moment to talk about our process for ensuring the accuracy and completeness of the data, since that's such a big part of our value proposition. As we distribute this survey to hospitals, we provide detailed instructions on how questions should be answered. And then we have a staff that's available to help respondents if they need support throughout the year. The platform we use to collect information has validity checks built into it. And we have staff that can identify anomalies and follow up on them to make sure that the data we're getting is accurate. Then we have a team of data scientists who can fill in the gaps from non-respondents through a rigorous estimation process. So it's really the combination of AHA's relationship with hospitals and our specialized platforms, processes, and people that make AHA's annual survey the source of truth for information about U.S. hospitals. Let's talk about this year's survey. So we had a really good year. We hit our target for completion rates. We have data for 6,173 hospitals in the system. Every year, there's a tension between asking all of the questions we'd love to ask and keeping the survey to a manageable size to support high response rates. This year, we added some interesting questions, new questions that I'll preview in a minute. The survey can be purchased now as either a data file if you want to use your own tools to analyze it, or through our hosted data query AI search and reporting platform. At the end of this presentation, I'll share my contact information as well as our URL where you can get more information. You can contact account executive or request a follow-up. The survey, as I mentioned, is extensive, about 1,300 data fields. It's divided into sections that include general organizational information, locations, ownership type, system affiliations, types of facilities and services provided, payment models, capacity and utilization rates, information technology details, staffing levels on a variety of different roles, and certain financial information. This year, we added some new questions about the rate of adoption of AI in different areas of clinical and non-clinical operations, as well as what challenges hospitals have faced in deploying AI. These questions were optional on the survey. We had a bit more than 3,000 hospitals respond to it. Before diving into the data, I wanted to quickly say the purpose of this preview is to demonstrate how the survey data can be used. And it's not to present AHA's interpretation of any of these topics. So I'm a product manager, not a policy expert. I'm going to confine my comments to the what and not the why. We are very easy to reach if you have questions about policy or interpretation. The AHA.org site has ways you can get in touch with us. Okay, so with that disclaimer, the first question we asked was, we asked hospitals what the rate of current AI implementation is in 7 different clinical areas. The chart on the left, the blue bar shows percentage of respondents who characterize their use of AI as either fully rolled out or expanding. The green section on each bar indicates hospitals that are exploring or testing in the area. And then the orange section indicates that they're currently not implementing AI in the area at all. So the picture shows that hospitals are pretty early on in adopting AI for clinical purposes, which isn't surprising. As I mentioned, we've been running surveys since 1946. With all the attention on AI, it'll be really interesting to keep an eye on these data items and see how they change next year. Hospitals are farthest along in deploying AI for clinical support, predictive analytics for patient care, and AI-assisted diagnostics, and less far along in using technology for resource allocation, population health management, and AI-assisted surgery. I just want to make the point here, this picture shows aggregated national numbers. The data set would allow drilling down by geography, by hospital type, all the way down to individual hospitals, if you would like. That's part of the power of the survey. I'm going to pause for a second so you get a chance to take in this chart. Okay, so we asked similar questions for non-clinical and in a non-clinical setting. And I would say, hospitals appear to be even earlier in the adoption curve in the non-clinical setting. Across all areas surveyed, the largest group of respondents are in that testing or exploring AI category. Revenue cycle management, things like automated coding, claims management, and fraud detection are being used by about a quarter of the responding hospitals. That's the highest rate. Patient forecasting, workforce management, supply chain deployments are currently being used by about 10% or less in responding hospitals. So certainly an adoption curve that people are moving up. We asked a follow-up question for all settings, and the question was what challenges hospitals have faced in implementing AI. I think consistent with this early days adoption that we just saw, most responding hospitals are facing multiple challenges. So costs, skill sets, regulatory compliance, interoperability of data have been challenges for about 60% plus of all responding hospitals. So that's again, I think consistent with what we're seeing in terms of adoption. In the staffing section of the survey, we added a bit more granularity on privileged positions, on contracted staff. And we also asked some interesting questions about which workforce programs hospitals factor into their strategic planning process. These were optional questions, and about 2,800 hospitals responded. The survey question is, how is your hospital incorporating workforce as a part of your strategic planning process? And what we can see is that recruiting, retention, and development are all viewed as strategically important in most hospitals. Interestingly, talent development is being viewed really holistically, from promoting healthcare careers as early as elementary school to partnering with community colleges, to tuition reimbursement programs, and ongoing training and development. We had a pre-submitted question from an educational provider about how the survey can be used to align educational services with hospital needs. And I think this is a good example of how this data can help with that use case. We also added some additional questions about services, including expanded information about the types of telehealth services provided and how they're being delivered. There was a higher N on these questions with a bit more than 4,000 responding hospitals. This chart shows types of telehealth and remote monitoring services provided, and then whether those services are provided by the hospital system, or through a joint venture arrangement. And what we see is that the use of telehealth for consultations and office visits is mature. Almost 85% of responding hospitals said they do that. So that's a large majority of hospitals. However, services like psychiatric treatment, remote patient management are less commonly offered right now. We also see that where these services are offered, it's predominantly through the hospital-owned subsidiary or the hospital system, and that joint venture arrangements are relatively rare. Again, I'd emphasize that we're looking at aggregated views and that responses can be drilled down all the way to the individual hospital level. So now we're going to shift gears and talk about a new tool we have for working with annual survey data. This April, we launched a product called Data Query AI that adds an AI-based chat interface to our data sets. We think it makes it easier for customers to access the rich information in our data sets, and it gives people who don't know how to write SQL or Python much of the same power that data scientists have. Uh, as I mentioned, I found that seeing the annual survey data in action is a great way to understand what it can do. And in a second, I'll toggle over and show you a demonstration. Typically, most people don't care about product architecture, and I took out the schematics here. In this case, I do think it's important to point out that we're using a private version of an LLM by a company called Anthropic, an innovator in the space that's running against AHA data that's hosted on our servers and walled off from the broader internet. And so what that means is the data is coming from only AHA vetted sources with citations. And we started thinking about this project. Our premise was, what if ChatGPT only had access to reliable information? And that's basically what this product is. We're viewing the Data Query AI platform as something that will continue to improve and grow over time as the technology gets more powerful. Because we're using a commercial service, we're benefiting from all of that R&D. As we continue to train it on the specifics of the hospital research, we're actively managing the product now and providing instructions and sample questions to help it be more responsive to the types of use cases our users have. And then we'll selectively add more data so it can answer more questions. I also just want to call out, this is a hosted service, but reports can be downloaded. They can include key fields. And so if your use case involves joining AHA data with other sources, you can still do that through this hosted service. Currently, we have 3 different data sources through Data Query AI. They're available for subscription. The annual survey data that we've been discussing all the way back to 2006. We have CMS cost report data, which provides financials reported to CMS back to 2010, and then IT survey data back to 2009. For subscribers with access to different data sets and years, the process of joining information and searching across data sets is really easy and provides a well-rounded picture of hospitals, of geographies, of segments. Okay, now the hardest part of this whole presentation is going to be switching over to my my browser. Okay, so we are in data query AI. I'm not seeing any chat, so I think I executed that okay. Uh, the the product is as I described it. It's a chat window where you enter your research question, and then the AI will turn that into code, run it against our database, and return a response. I like to show I chickened out a little bit here, and I'm showing a session that I did earlier this morning rather than having a group of people watch me type badly in front of you. So these are searches I ran a couple of hours ago. A good first question. What information do you have? And actually, we're really seeing that this is something that people like a lot. I asked, give me all the information you have on beds and utilization. I get the field name. That's what you would use if you were downloading this data and running it in another program. I've got a field display name, something that humans can understand, and then a complete field description. Here I can see there are 85 different fields that are tagged as being about beds and utilization. Um, I can go into any individual question and I can see what the response rate in that question was. So that this meta information about the survey and survey responses, has been surprisingly powerful. Here, if I see something that I don't understand, I can ask a follow-up question. So I asked, what's the difference between a staff bed or a licensed bed? Because it has this information from the description, it's able to go and look and say, well, staff beds are beds that are actually set up for patient use. Licensed beds are authorized, but not necessarily in use. Um, Here's an example of creating a table for download. So I asked for a downloadable list of hospitals in Chicago with the hospital name, their provider ID, total number of beds, total admissions. I could have added any other information that I wanted. I could have asked it to sort the table in using any criteria that I wanted. It returned the list of 39 hospitals in Chicago. Uh, just so you see it, when we talk about generative AI, what's being generated is computer code, right? So that query I entered, give me a list of hospitals in Chicago, the AI turned it into this little snippet of code and then ran it against our database. Um, this table, I can download it as a CSV if I want to work with it outside of our program. I'm looking at the table and I see no Medicare ID for this hospital. Must be missing data. If I actually read what the AI is telling me about it, it says, hey, note that two hospitals don't have Medicare provider IDs because they're VA facilities. Okay, so helpful. Okay, in addition to just the survey data, I'm getting this extra intelligence about uh, um, what's included. A different use case, I asked for a bar chart that shows admissions in Chicago over the last 10 years. So it goes away and thinks, and it creates this table so I can see the source data. And then it creates the chart itself with nice little mouse overs. I can copy this if I want to drop it in an email or a document. Here, I'm noticing that, okay, right there, it's been declining, a little increase in the last year. I wonder what the the annual growth rate is. So I asked, what's the CAGR? It understands my context, so I don't have to restate the whole question. It knows what a CAGR is, and it calculates that. Over that 10-year period, its admissions are declining by negative 1.3%. If it hadn't done this, I could have asked the follow-up question, which is, how did you get that answer? I think because I've done this presentation so many times, it's anticipating that I want to know that. So it's telling me what formula it used. It's showing me the data that it grabbed. So if I wanted to check the math, I could do that as well. Here's just another example of a type of calculation that we can run, right? The number, I wanted a ratio of registered nurses to beds in Chicago for 2023. I asked for cumulative, so it's going to give me a total number for the 39 hospitals in Chicago, and tell me that the ratio is 2.56. If I wanted the supporting information, if I wanted to see this broken out by individual hospital, I could just ask for that follow-up question. And then perhaps relevant to this presentation and the fact that we have a new data set coming out, not loaded here yet, but will be in December. You can ask the chatbot to do more abstract things. So here I asked it, just give me a summary of important changes for hospitals in Chicago for the most current year and the prior year, right? So that's somewhat vague. I didn't give it, a lot of specific parameters. So it goes back and it looks at the data and it makes some comparisons, and it comes back and says, increase of 2 hospitals, beds, admissions, inpatient days, outpatient visits, all grew. Staffing jumped. Registered nurses grew by 10.4%, right? So there's a real power to the AI. I think so far we're seeing most use cases be simple calculations or reports, and a handful of people who are using it for more sophisticated types of analysis. And I expect that we'll see that change as AI becomes more pervasive in the workplace. Okay, I am going to toggle back to the deck. Okay, we're back to seeing the slide deck. Okay, so looking at the Q&A section here, and there are some questions. I'm going to try and pick some of them off. There's a question about how many nursing variables we track. So we have full-time, part-time, full-time equivalent staffing levels for LPNs, for RNs, and for advanced practice nurses. That's not broken out. APNs are not broken out further. Another question about what data we have. Do you have emergency room visits? Yes, we do. We have outpatient ER and non-ER visits, and we also have a number of ER beds. Here's a question. Can I cross-tab on rural health systems and profitability? So the first part is easy. The rural designation is in the data. You can identify rural hospitals and cross-tab against any other dimensions you want to. AHA doesn't publish financial data like profitability. However, we do integrate the CMS HICRIS reports. And so if you have access to that, you can, add financial dimensions from them to your searches and data query AI. And we also, if you want the file to accompany an annual survey data file, we can do that as well. Here's another educator question. So, how can universities play a more strategic role in helping hospitals achieve their workforce development goals? Um, we didn't ask that question specifically, but as we saw, we do have information about which hospitals have educational partnerships, which ones are viewing uh, um, post-secondary or secondary education as strategic, which have tuition reimbursement plans. So, I think here the data could help you zero in on hospitals that you could have that kind of conversation with. I have another question. How do I understand all the changes to the survey? So here, we published the survey instrument on our website on the screen, hadata.com. We have account executives that can provide, a lot of detail on what information's new, what information may have been removed as well. Really would encourage you to look at the website and give us a call if you have questions. Our account execs are fantastic. Another question, can I access the data set through Words, the Words platform? That's lives in academic libraries. And the answer there is yes, we do have tiers of access, including trial access through the Words platform. Can I merge AHA data with other data sets? I think we covered this. Yeah, it's a common use case. We have AHA ID and provider number as key fields. So every hospital has that. Our field names follow conventions that programs like SAS will understand. And if you buy the data file, you get a data dictionary and all of the information you would need to do your mappings. Okay, so I think that's going to do it for Q&A. If we didn't get to your question, or if you have a follow-up, I really encourage you to reach out to us through ahadata.com. Here's my contact information. There is a event survey coming around. We'd really appreciate your feedback on how to make these webinars valuable to you. I really appreciate your interest in this subject, which is near and dear to me. So thank you for your time. And with that, I think we'll close the webinar.